All right, who's doing the intro?
I am. Welcome. Hello, everyone. Welcome to this webinar, co-sponsored and co-hosted by the UCSF Center for Community Engagement and Latinx Center of Excellence. Thanks to the hardworking staff of Faithful Fools, Tenderloin Community Benefit District, and TNDC for their help planning today's event. A big thank you to Elena Pfeffinger of the Latinx Center of Excellence for making the webinar possible. She's the hand on all the controls here. My name is Paula Fleischer, and I'm an Associate Director of the UCSF Center for Community Engagement. I'm honored to also sit on the board of the Tenderloin Community Benefit District and the Community Advisory Committee of the Tenderloin Health Improvement Partnership. The Center for Community Engagement is dedicated to ensuring that UCSF researchers, healthcare providers, and educators are responsive to community health needs in the pursuit of health equity in San Francisco and the Bay Area. To that end, we're pleased to provide this forum for 4 of our experts to offer the latest information on the COVID-19 pandemic to organizations serving the Tenderloin neighborhood, a beautiful and dynamic place that is home to a great many of San Francisco's low-income seniors, families with children, and immigrants, as well as residents experiencing homelessness, living in shelters, SROs, and other housing arrangements that make it extremely challenging to be safe during a viral pandemic. Today's webinar is meant to share knowledge that will help those serving the Tenderloin continue to do your very best to make sure everyone in the neighborhood can be healthy and safe in the face of COVID-19. Our panelists today, Dr. Lee Kimberg, Dr. Josh Bamberger, and Sissy Bonini will introduce themselves and make brief presentations. Then we'll have a question and answer session after that. Please submit questions through the box on your screen. If we can't answer your question today, we'll do our best to get back to you via email directly. This webinar is being recorded and will be posted on the Latinx Center of Excellence website. So thank you everyone for being here. We really appreciate everything everyone is doing in these difficult times. First, we're going to hear from Dr. Lee Kimberg.
Hi, everyone. My name is Lee Kimberg, and I'm a professor of medicine in the Division of General Internal Medicine at San Francisco General Hospital. I have the privilege of having worked for the Department of Public Health in San Francisco for 20 years at Maxine Hall Health Center as a primary care doc. And I'm doing violence prevention work for my entire career. So I'm here to be a resource for you, but as Paula said, to make sure that we take your questions, and if we can't answer them today during this webinar, that we get back to you with more information. Great, next slide. So I always want to start with, especially because I do a lot of violence prevention work and trauma-informed care work, I learned the hard way that it is so important to try and stay grounded while we do this work. For me, thinking of staying rooted like a tree and letting my weight sink into the healing energy of the earth, growing those roots really deeply and solidly, knowing that sunshine and oxygen are around me, but so is carbon dioxide. And that if I stay really rooted and grounded, I can draw in all of those things and breathe out life-giving oxygen. So I just encourage you to think of what comes to your mind when I say the word healing, and to just let yourself really take that in and feel it while we all experience, the really major exacerbations of stress and concern for what's going on right now. Thank you. Next slide. So one thing that we're going to talk about today is just transmission messages. And what I wanted to really highlight about that is that in order to earn trust, we need to explain the science of transmission very, very simply without jargon. For everyone, regardless of educational level or background, explaining very carefully and simply that this is coughed out as invisible droplets of of mucus and phlegm that one can't see with their eyes, that coughs can travel a little less than maybe 6 feet. And so it's important to stand 6 feet away from other people in case they are breathing out or coughing out particles of this virus. And that because of that fact that we all speak and cough out particles of this virus when we're infected with it, that it can fall and settle on every surface around us, so that we should assume that everything we touch, whether it's a doorknob, a desk, a table, that could have virus on it. And so we need to not touch our face after touching those surfaces, and we need to wash our hands really carefully. And the easy thing for everyone to remember is to scrub your hands with soap while singing Feliz Cumpleaños or Happy Birthday or whatever that is in your language twice, to try and wash your hands long enough. I think in terms of earning trust, it's really important for us all. You all do incredible work trying to rectify all the structural inequities in society. It's really important for us to acknowledge all of the things that make it more difficult to prevent transmission for people who are experiencing structural inequities. That, for example, there aren't places to wash your hands, that you may be living in an exceptionally crowded space or on a crowded street corner. All of those things we need to acknowledge, that it is harder to prevent transmission in those under those circumstances. And then we need to really brainstorm creative solutions, and we're hoping in the question and answer period that will be possible for you to contribute your ideas. And if not, I just consider this the start of a dialogue. Yeah, next slide. So Paula asked me to do a little bit on the epidemiology, and I think one thing that's been really disturbing in watching our governmental leadership, especially at the federal level, but also many state levels, is we've learned that people did not understand the basic math of an exponential curve. And so when you have an exponential curve and cases are doubling, say every day or every 3 days, however often, 1 + 1 only equals 2, 1,000 + 1,000 equals 2,000. And so as you can see, these are the cases, the total cases in February and March in the United States. Nothing looks like it's a problem until suddenly it's a huge problem. And so there's been mathematical modeling out of the University of Texas in Austin looking at when is it a problem, and it has been identified that if there is one case in your community, you can assume that there is community spread within the community and that you're just not seeing it yet because people are not ill yet or there's not enough testing happening. Next slide. So there's been a lot of talk about flattening the curve. I feel like also the terminology about flattening the curve is changing a little bit, but what it originally referred to is that if you saw and remember that exponential curve from the last slide, if we allowed the spread to keep doubling that frequently, our hospitals would become completely overwhelmed once we got to the steep slope of the exponential curve. So what flattening the curve was raised as is the concept of if we immediately, when there were very few cases and we were in that flat part of the curve, if we at that time took aggressive measures to try and keep people more than 6 feet apart from one another and doing all of these preventive transmission measures, we would be able to markedly slow down the spread of infection so that hospitals would never get overwhelmed and we would be able to care for people. So looking at the doubling rate and how fast it is going is an indication partly of how quickly this is spreading. As you've all heard, and I know is very much on our minds today and throughout this entire epidemic, is that there were huge failures in the country developing tests and distributing tests. So some of the numbers are hard to interpret because we don't know whether the pace of growth is accurately reflecting infections. And in fact, we know that it isn't because we're not doing widespread enough testing like some countries, for example, South Korea did. So it's hard to tell how quickly it's doubling, and we're mostly going via hospitalization rates and understanding how many people are becoming ill and coming into the hospital. Next slide. So as I was saying, without testing, it's hard to know. These are the two best sources of data that I think are good to look at. The SF data now is looking at various indicators, because what we're finding is that there are very large inequities in all communities in our country in terms of who has access to testing, who has access to testing with a rapid turnaround time, who is getting an infection. For example, if you are working in a job in which you cannot actually stop working, you're a grocery store clerk, and you're going to work every day, coming in contact with a lot of people, you're at higher risk of infection. And then people who are living in very crowded living situations are also at risk. And then not having access to healthcare promptly, or not trusting the healthcare because of the racism and the inequities in our healthcare system leads to also people coming to the hospital later sometimes than otherwise. Next slide. So this is the most up-to-date data that we have, courtesy of the Family Medicine Department putting this chart out today for us. But if you go on that SF.gov link that I had in the last slide, you'll be able to find now multiple visualizations of the San Francisco data according to race, ethnicity, gender, and other characteristics. So what I've done here is highlight for you in red the populations in which the percent positivity for COVID is higher than the percent that population is represented in the community of San Francisco. So you can see that the most affected community at this point is the Latinx community with a 5% higher positivity rate than residents in San Francisco. The other category usually are a mixture of people who are not white of European descent. Next slide. So I think because you have so much contact with, at least by phone at this point, with the people that you are caring for and serving, it is really important to know the most prominent symptoms. Fever, exceptionally important to ask about. The hospital is now today, this is hot off the presses, recommending that we actually ask about fever, chills, and night sweats because it's more reliable than just a one-time temperature. So actually asking people if they've had fevers, cough, especially like a dry hacking cough, shortness of breath, chest pain while taking deep breaths, feeling very sore in your muscles, a lot of muscle pain, some sore throat and fatigue. And then these other symptoms are not as common, the symptoms at the bottom, but there's a very particular symptom, losing one's sense of smell or taste, that if you have that, it can be very indicative of this infection. And so even though it's not present in a lot of people, I do find it helpful to let people know about that symptom in case they detect it. Next, I think that might be. Okay, so we're not going to do that right now. So I think, or did you want me to do violence right now?
Sure. Why don't you just go ahead and
Okay, sure.
we'll
So
proceed.
one of the things that I've been really concerned about immediately, and that's how I actually ended up being activated by the Department of Public Health to help with this epidemic, is that I got a call from a domestic violence shelter that they were worried someone was infected. And knowing what I know about how people are hurt in their relationships, the idea of shelter in place was brilliant in terms of preventing infection spread. And I was profoundly grateful to Bay Area leaders as well as California leaders for implementing shelter in place right away. Because as you can see from that exponential curve, that was critically important to prevent us from being in a community where there's much more marked spread. At the same time, shelter in place, knowing what I know about the hidden epidemic of how much people harm one another in relationships, I knew was going to markedly increase the prevalence of interpersonal violence because economic stress, social disintegration, not having multiple supportive people in your life, all of those things can exacerbate or even start a cycle of really power and control in relationships. But they're also, this is a hidden epidemic, and being locked up sort of 24/7 with someone who's hurting you is going to markedly increase the risk of harm. And then having people not be able to access in person all of the people in their lives that were supportive to them, family, friends, case managers, healthcare providers, lawyers, means that people have less outlet to get help if they're being hurt. And then children being isolated. There's a very large crossover between adults in a family or a relationship having a cycle of interpersonal violence and children also being harmed in that situation. So just to say, for all of us, we all need safe, stable, and nurturing relationships. And what is happening right now is really presenting a huge challenge to fostering and promoting all of those safe, stable, nurturing connections. Next slide. So one thing that you can do, we found in the healthcare setting, we used to try and promote a screening approach to addressing interpersonal violence, and we have shifted to a new approach that we call universal education. The reason we did that is because one, providers were actually uncomfortable enough about asking these questions that they either didn't do it or did it uncomfortably. And two, people have a huge array of reasons why they would not want to disclose that they are being harmed by their partner, or disclose that they are actually harming their partner or someone else. So we are asking people to use proactive universal education, in which you say that you know that stress can affect our relationships, that this pandemic is really causing a huge amount of stress that could increase fighting, could increase even severe harm, that there is help available, and that you offer a hotline or some resources to people before you ask direct questions so that people have that information. Another way to normalize it is to say that you'd like to offer this information for people to share with family and friends, because most people don't disclose to service providers, but they actually are more likely to disclose to a family or a friend. So it's really wonderful when people know what to say, what to do, and have the numbers available. Next. Certainly in all of your phone contact with people, giving supportive messages, letting people know that they're not alone, that you are there to listen to them and be a supportive listening, compassionate listener. And then knowing that it's really hard, very painful to hear that someone is sheltering in place with someone who is hurting them. It's quite agonizing to deal with. So I just encourage you to get advice and support for yourself if someone discloses that they are being harmed. Certainly also, if someone discloses to you that they are harming someone else, all of the domestic violence hotlines locally and nationally and child abuse lines, people are used to talking to people who are also harming others and are ready and willing to try and counsel people who are either concerned that they might harm someone or are feeling themselves distressed. One thing that's very motivating is if people recognize the impact on children that are witnessing this violence and this harm, that may be a very motivating factor to actually call out for help and try to prevent the exposure of your children to this. Next slide. Oh, okay. I think there might be one more. Is there one more? No. Okay. I will send you another slide later of the LEAP website. It's www, we'll put it in the chat box. It's www.leapsf.org. And I have put on that website a guide to telehealth, but it could be used for any type of phone counseling to understand how in this time to address COVID and violence and how they're intertwined over the phone, and how to do the universal education, and as well how to try and figure out whether it is or isn't safe to talk to someone who you know is experiencing interpersonal violence, and how to have that dialogue to establish a safe time to talk. There are safety plans in 9 languages on that website. And lots of other helpful resources for interpersonal violence and COVID and how they are intertwined during this time. So for those of you who are old enough to know about Lassie, I do just encourage you to take care of yourself while you're taking care of others. Thank you.
Thanks so much, Lee. Thank you so much.
Mm-hmm.
Terrific. We're going to turn it over to Dr. Bamberger.
Hi. Well, it's been quite a day. Things are happening very fast in the world of trying to reduce the spread of COVID-19 among the homeless. The next slide, please. So basically, our strategy for trying to prevent transmission rapidly among the homeless has been pretty straightforward, trying to implement the recommendations for many folks who are housed in settings where they're not, and that has some effectiveness and some not. The recommendations that the health department gave to HSH around shelters is to try to create 6 feet between beds, to provide hand washing at the shelters and on the streets, hand sanitizer, to provide masks for all residents and staff, and try really hard not to move people who are very frail and dependent on the services in shelter into hotels where they might come to harm for the problems that they live with on a regular basis while they're trying to avoid getting into harm from this virus. We've identified hotel units now for the frail and elderly who are in shelters, and we've started to move people who are at greatest risk for coming to harm from COVID-19 into these shelters, in addition to trying to identify people who have the illness and people who are under investigation. But today it was a launching day. So next slide, please. I wrote this yesterday. It's already out of date. We now have 5 cases in the shelter. I think, folks, we had this brief period of time beginning around the 7th of March until the 1st of April, where we were given a opportunity to get prepared. And I think one of the reasons why the infection did not hit the homeless population in San Francisco for those last 3 weeks of March was because I think the intersection between communities is much less than we may envision. I think that many homeless people in many homeless communities were sort of insular to a certain extent, and they weren't intersecting with the population that was infected with this virus. I think once people got their checks and they went out to pay their bills, to score some drugs, or to whatever else they needed to do to get through their day, there was this intermixing of populations that we're now seeing explode. So we had, as you know, our first case at the Division Circle Navigation Center last Wednesday. We had 2 more cases at MSC South on Sunday. And then today we had 2 cases of contacts from those 2 people at MSC South, also at MSC South. So now and those folks were both asymptomatic. When they were tested, they were found to be positive. So we have a really big difference that's happening right now. We know that asymptomatic spread is happening rapidly in the shelter. We did not do our job of getting people out of the shelter and into adequate hotels, and we have not spaced people out. So we are really in a difficult time. We can look ahead to 2 weeks from now where things are in Boston, where there are 200 cases of COVID positive among the homeless in Boston right now. And more than half of them have been tested and found to be positive despite having no symptoms. So we're about to launch here, and we are doing everything we can to try to stop the chain of infection. So the way that things are going today at MSC South is the way that they're probably going to go in many other shelters very soon, which is trying to get people who are most at risk for coming to harm from this illness out into hotels, in addition to getting people who we know are positive or people who have symptoms out into hotels, and then trying to decompress the shelters. So that's where things are today. Next slide, please. We do have a 24-hour medical assessment team. So if any of you in the Tenderloin or working in shelters or with people who are on the streets, find someone who is symptomatic, there's a phone number you can call so that we can come in and try to help to assess if people need to be in isolation and quarantine. We're doing daily symptom and temperature check in all of the shelters. We've closed the shelters to new residents to try to prevent this sorting, which obviously didn't work now with this expansion that's happening right now today. We have established our protocols, and we have transportation in place for isolation and quarantine. And we, for a minute, had an auxiliary shelter at Moscone West, and now we don't have that, but hopefully we'll have another soon. Next slide. When we do have a case, we try to intensify our services by providing more on-site symptom screening and lower the bar for who goes into isolation and quarantine, not just for people who are febrile, who have fever, but also people who have just mild symptoms. And we did that a lot today at MSC South, transferring a lot of people into isolation and quarantine who had very mild symptoms. But mostly we were just trying to push the system so that we could have them qualify for testing. And then we do contact tracing. So anyone who's had intensive interaction with people who are known to be positive, and that's where we found these 2 cases at MSC South. As I said, we lower the threshold for symptom screening. The good news is that today we are testing everybody at MSC South with PCR testing. Starting at 3 o'clock this afternoon, the public health nurses have come in and is offering testing to all residents of MSC South and all staff. And I hope, and I guess I pray, that becomes the standard. I look forward to having a mobile testing unit that will go to different parts throughout the city. Maybe Monday will be next door shelter, Tuesday will be the corner of Hyde and Jones, and then, or they don't have a corner, Hyde and Golden Gate, and then the Wednesday would be another corner, and then onto shelter. And we have to start using testing as the strategy to find people who are likely to be infected, and then helping them to get into hotels as quickly as possible so that they can stop the transmission. So next slide. I think that's pretty much, testing is difficult. So there are harms to testing that we have to embrace. The false negative rate of the present PCR testing is high. So that means almost 1 of every 3 people who are truly positive will test negative. And that's a problem. But if we keep testing sequentially and using symptoms as another strategy to find true positives, we should be able to find people relatively quickly. Ideally, the answer is everyone has to be in their own home. So despite our efforts to test people in shelters and on the streets, we need to increase the number of hotels that are available much at a greater rate than we are. And we are trying with all possible speed, but we also have to recognize that for housing to be effective, it also has to have services. And we are really limited in the service staff that could be provided in these hotels. And then last slide, please. Last most important thing, everyone deserves a home. This epidemic has proven to us over and over again how we have failed as a society to provide what should be a human right, which is a place to live. And that for many people who are living with substance use disorders and chronic medical problems and mental health disorders, they need the three components of permanent supportive housing. It needs to be permanent, it needs to be supportive, and it needs to be housing. And right now in this epidemic, we are successfully finding housing, but it is not permanent and it is not supportive. So what will this be like in 3 months? We don't know. And with the 2.5 million Californians who applied for unemployment benefits last week, how many new people will be coming to the streets in just a few months? Will our best selves be shown, or will we become more of a police state? It could go either way, and certainly the election for the president in November is going to be a critical time to determine how our future will be. Next slide. So I'll leave you with my contact information, and let's get to some questions.
I think we're going to do food insecurity first.
Okay, that's not good as a question.
Josh, there is a question though, a request for the phone number for the medical response. You mentioned a phone number, so maybe you could send it to us in the box and we'll post it. Okay.
Okay, let's see if I can figure out how to do that.
Thank you.
It's my phone number. No, I'm answering it right.
Okay. All right, Sissy, we'd love to turn it over to you now. Thank you.
Okay, thank you. Thank you, Josh, for that. My name is Sissy Bonini. I'm with the UCSF Center for Vulnerable Populations. I am part of the Food Policy, Health, and Hunger program. I am also the executive director of Vouchers for Veggies, which is known in San Francisco as Eat SF, which is a healthy eating program for low-income San Franciscans. I also run the San Francisco Food Providers Emergency Communications and Coordination. That is the major food providers in San Francisco, such as Food Bank, Meals on Wheels, Project Open Hand, Glide, St. Anthony's, et cetera, in terms of our disaster coordination. I'm also part of the City and County of San Francisco Feeding Unit, operating out of the Emergency Operations Center at Moscone Center. So what I have today is just a real brief rundown of some food resources in the Tenderloin. Go ahead and change. Great. So as we know, all folks on this call are super familiar with the Tenderloin, so we know the pre-existing food insecurity issues, that kind of, as Josh was talking about, the pre-existing homeless conditions. So it's already an uphill battle. One of the things that is happening as a result of COVID-19 was really a lot of changes in how food was and is being provided. For example, all of the congregate meals immediately after the shelter-in-place orders and other orders eliminating congregate meal provision switched to to-go meals. In certain cases, especially for some of the senior congregate meal sites, the idea was to really reduce the frequency that people need to leave their homes if they do have a home to go and receive their food. So some of those sites will be now, instead of a daily meal, will be giving out packages of 7-day meals. Again, these kinds of changes so that folks don't have to go out as often. There's a lot of challenges. San Francisco Marine Food Bank had 100 pantry locations closed due to those facilities closing and lack of staffing. So there was a lot of shifting locations going around, and later on I have a website for where the latest of the food pantry locations are, and we'll talk a little bit about what specifically was happening in the TL. We know that the kids are out of school and have limited access to school meals in the Tenderloin, so I'll update on that. A lot of folks live in SROs in the Tenderloin and do not have adequate kitchen facilities, and also do not have the ability to stock the 7-day food supply on hand, because folks don't have enough food in general to make it through the end of the month. So that's a real challenge. And then, of course, social distancing and quarantine, very difficult in the Tenderloin and other compact neighborhoods. Go ahead to the next slide. So what is currently happening? Meals on Wheels is made a huge effort. Most of the larger feeding programs have really lost a lot of their volunteers, many of them older adults, and are working with reduced staff loads, but they have uninterrupted service and contingency plans. Again, they are delivering, instead of daily deliveries or other days, that they're just delivering more food, less frequency, but they are continuing operations to all residents in the Tenderloin. Project Open Hand likewise has they're expanded their services, but they continue their service to their regular clients, including their grocery services, although everything is outdoor. And again, from most of these programs are moving from less hot meals to more cold or frozen meals that need to just be refrigerated and then cooked at home in site. As I mentioned, the congregate senior meal sites are continuing to serve, such as like Curry Senior Center, but with to-go meals, so in a different way. St. Anthony's in Glide, they have, St. Anthony's continuing its lunch service and is experiencing a large increase in numbers, but all of these programs have worked on line spacing, and many of these organizations have had visits from industrial hygienists to ensure that their operations are sanitary and effective, and they are continuing to try to meet their social distancing requirements both outside and inside the facilities, but they continue serving. Glide likewise is serving, but they are not serving the lunch meal. They're doing breakfast and dinner, and as St. Anthony's is taking on the lunch in the Tenderloin. And those services are open to everyone, with particularly St. Anthony's with special earlier services for seniors. And next slide. Okay, so there's many gaps for food resources still in the Tenderloin. It has been identified as a priority for additional food resources. For example, there is absolute need and interest in creating more pop-up pantries. The San Francisco Main Food Bank is doing a pantry that a lot of the other pantries you have to be registered for, but these pop-up pantries are people can just show up to and receive groceries. So they are still looking for and trying to solidify the location that would be in the Tenderloin. So I have some resources at the end of this where you can look it up. So when that does get online, that is a good going to be a good resource. School meal sites, again, the Unified School District has, because school meals are not schools out, they are giving food to not only children, but also families. They've received some funding so that they can serve more than just children. They can actually serve families. They have been working diligently to try to find a spot in the Tenderloin, and they've been working with folks at TNDC and Parks and Rec and DCYF, and probably some of these folks that are on this call. So they're hoping to get that solidified as soon as possible. Food. What's interesting about the Tenderloin, and particularly around, and Josh was talking about the situation with homeless or unsheltered folks, and there are a lot of folks that receive their food from Glide and St. Anthony's in particular. That are unsheltered. And so there is an effort to, again, in combination with Josh was saying, is really trying to get those most needed into different types of shelter and hotels. There is a recommendation that encampments are, that you, folks that are safe, if they're safe in their encampments, to leave those encampments and try to perhaps deliver some food to those encampments so folks do not have to leave to go out to the congregate meal sites. So that's there's discussions around that and about trying to, how do you access food delivery to homeless folks in many different ways. So that's a conversation that continues to happen and is a priority. SROs have some unique challenges for folks to access food. Again, we talked about Meals on Wheels. So the home delivered programs are still accessing the SROs, but there's some challenges getting food to folks at those sites so that they don't have to leave their housing site. Again, I think there is task force and groups working on ways to increase food to SRO-specific populations, but that is a big challenge that we haven't figured out yet. That's the update. I'm sure there'll be some questions later on at the end of the presentation, and I'm happy to answer.
Thank you so much, Sissy. Thank you. And thank you. Okay, here's some resources. We will be making the slides available to folks. And I believe we just put up the phone number for, for medical response.
Not 24 hours, probably 8 to 8, but we'll do our best.
Thank you, thank you. So let's go ahead and Cameron, who's monitoring the questions, how about if you help us by reading out some, and anyone on the panel could jump in.
Great. Thank you very much, Paula, and thank you to everybody who spoke today. My name is Kamran. I'm a second-year medical student at the UC Berkeley UCSF Joint Medical Program. Great. So the questions, one of the first questions that came up was actually in reference to some of the physics of transmission that you were talking about at the beginning, Lee. How long do the droplets remain in the air after someone has passed through?
Sure. So that is a subject of scientific debate, but I would say on average, people think that if you cough out the particles, they could remain as little as like maybe 30 minutes and as much as 3 hours. Hence the 6-foot distance, because it's unlikely to cough particles that far. Of course, the sneeze can travel like almost 30 feet. So, the mask debate was muddled because there wasn't enough protective gear for healthcare providers. So the public health messaging that people shouldn't be wearing masks was partly based on supplies. We do think that putting a mask on someone who has a cough is not perfect, but it prevents a lot of those particles from going into the air. So 6-foot distance is based on knowing that there could be some of those particles in the air. We do not have the science, I don't think, to know exactly what small percentage of cases are transmitted by airborne rather than particles that have settled down on surfaces. The vast majority is thought to be particles that have settled down on surfaces.
Thank you. And there was actually a follow-up question posted by somebody regarding the new things going around about wearing masks in public. So should we start wearing masks when we're going out in public? And what do you know about whether or not masks or cloth masks are effective or not?
Yeah, so there was a really fascinating article in the New York Times about how to make your own mask and what cloth masks are effective. I would say a general rule is the less you can see through the fabric, the more protective it is. So calling all quilters, apparently quilters cotton is very, very dense. And 4-ply quilters cotton is almost as good as a surgical mask. But again, sort of see-through bandana that you can hold up to the sun and see lots of light coming through it is not as effective as a 600 thread count pillowcase fabric that you can't see through as well. And it does seem to be about a 4-ply of a cotton mask works better than one and is pretty decent. We certainly are hoping that people who have any sniffles or coughs or sore throat or any symptoms would certainly wear a mask. And then we do know that there is asymptomatic transmission. So that is the rationale behind asking people to wear masks.
Thank you. There was a question regarding the rolling out of testing for unsheltered folks. So The question is, are you hoping that testing will roll out next week, or is there an actual plan for testing that will bring testing to the community? So part of what I'm hearing in that are like, what are the concrete next steps for rolling out testing?
Yeah, thanks for asking. I mean, I don't know the answer to that yet. I am very pleased that testing is now being offered to asymptomatic homeless people in San Francisco. That has been the case in Contra Costa County, in Oakland, in Berkeley, in Santa Clara, and San Mateo. And today we joined the rest of the Bay Area in doing what I think is the right strategy for trying to diminish transmission among homeless people. Now that we've had that opening, let us continue to advocate strongly for making this available to people on street corners and in shelters. How that can be done is practically challenging, and we're working very hard to do these things quickly. My hope is that we can use a mobile testing structure. We have to staff it up. It doesn't seem that the rate limiting step at this point is availability of testing, which is fantastic. That is very different than it was just a week ago. So hopefully we have sufficient testing capacity. We just have to figure out how to get the tests out, and then how to adequately respond to both the false negative and false positive that can happen to these with these tests. The challenge, of course, we are now entering a new world where we're testing 100 people at MSC South, but we're not necessarily putting all of them into a hotel today. So we're going to have people who are going to be going back into shelter with their results cooking, which is daunting.
Definitely. There are a couple questions regarding the plans for moving folks inside or trying to better handle spread on the street. So the first question to this is regarding the staffing comments you made previously, staffing being challenging in the hotels with social services and things. So one person asked, does it make sense to move everybody from the shelters into hotels and then move those shelter staff over to staff the hotels? And then regarding specifically this thought of how do we manage it on the streets, there's a question of what do you think about using larger spaces like the Civic Center or Union Square as places where people might be able to set up encampments?
Yeah. So first of all, excuse me. Uh-oh. Um, the to the question about moving people en masse into hotels, that would be the strategy that makes the most sense to me. And I know that at at Women's Place yesterday, they tried to move all the 32 women, I believe, who are at that shelter into one hotel and move all the staff to work there. And that works, right? Because staff knows the shelter residents, and you don't have to double the number of staffing to keep the shelter going at the same time that you're doing the hotel. That's a lot harder at the 360 bed MSC South, which is much smaller in terms of bed capacity right now for a lot of the reasons we talked about. But that would make a lot of sense, but you can't do both. And that's where we're straddling that fence right now, trying to figure that out. But I like the way that question is asked, because I think the question is asked with the solution embedded into it. And so I would love to see that happen. It's hard to imagine how it works. And then again, what are we going to do in a couple of months, right? Do we move people back into shelters and then keep having these outbreaks in shelters and moving them back and forth? And when will we get to the point where we give everyone a home, and how will we make that work? So that was the second part of the question, just about what to do on the streets, folks on the streets, and like
Yeah.
plan encampments. I'm really ambivalent about plan encampments, and I suspect there are other people who are on this call who are more experienced in this space than I. My career has been spent developing housing for homeless people and providing services for people in supportive housing. I am not expert in how best to serve people who are living in encampments. What I do think is that if we can give people the resources that they need to make their best choices, to honor where people are making their choices, and then to give people choices so that they can choose what's best for them, it always works. Whether that's helping someone with their diabetes, their blood pressure, or their homelessness, I think we have to honor the autonomy and the wisdom that people carry with them throughout their day. So I think the best answer around how best to serve people who are living in tents is to ask what do they want, and then not getting in their way to get it.
Thank you. One follow-up to that that was posted, and then there's a question for Sissy. Why haven't we been able to get the hotel rooms for everybody, and what are the roadblocks to obtaining those spaces?
You know, there's so many parts to this. I mean, there's so many stories that should be written and analysis that will be made and learnings that can happen. You know, part of the problem is the health department is pushing in one direction, HSH is doing another. So we have this bifurcated city system. HSH is working as hard as they can to try to find contracts for hotels, but then we don't necessarily have the services again to provide them. And then we have a lot of sick people who are in shelter who might come to harm if they go into hotels. So all these things have been happening simultaneously, but the bottom line is we just haven't moved fast enough because often we really haven't had to, right? We got this 3-week or 1 month sort of free pass. I think today is the day we're crossing the Rubicon. You know, it's the first day we have, you know, our first 2 asymptomatic positive homeless people in the shelter should finally get the message that we need to now find a solution so that this doesn't become the epidemic that it is in New York and Boston. We are on the edge. We have the resources to do this. We got to accelerate and get it done.
Great, thank you. A question for Sissy and the EDSF folks. So there are a lot of folks who are not quite in the vulnerable population's age group and are afraid to go outside for various reasons. What is being done for this population? I understand that Meals on Wheels isn't accepting new applications unless you are part of the vulnerable populations group.
Yeah, I think that's a great question. I think that what we're trying to do is increase the food resources in the Tenderloin, that people don't have to go out every day to get meals from where the congregate sites. So that's where we're trying to get more pantry services, working with the SRO and the housing providers to try to get more resources to the housing sites so that people don't have to get out. But that is it's a gap that I want to say has been brought up a number of times, but it's a challenge we're trying to fix right now, but it's absolutely a gap.
Thank you. There's another question about the timeline of the pandemic. So I heard the president mention that this would all go away in April. When can we expect the end of this to happen?
I can definitely say not in April. We haven't had widespread enough testing, given that there is asymptomatic transmission, to properly contain this. So we're trying a variety of catch-up strategies that Josh has described, that we are trying to expand testing more widely to try and catch asymptomatic cases. We're trying to expand investigations of contacts of cases, as well as separate people who are in living situations where they can't prevent the transmission to other people in their living setting, whether they're sharing a bathroom or there's too many people in one small space. So we're now trying to play catch up with a variety of strategies to prevent the spread. We will continue to have spread. If we are very successful in doing these catch-up strategies, I think each time we let up, we'll probably have small bursts of other infections that come up that we then need to deal with again. So I do not know exactly when shelter in place will be lifted, but this is going to go on for quite some time, probably into the early summer at least. And we'll have to see. And it also depends on how quickly science advances and how quickly someone can develop a vaccine, because that would be a godsend if people could develop a vaccine.
But I think for the Tenderloin, it's very important to look at the curves that have been in the housed population over the last month and now move that 1 month forward. Because I think that's what we learned today, is that we are just at the beginning of the spread among homeless people in San Francisco. So our peak is going to be mid-May, is my guess. That we're going to, I'm working as fast and as crazy as I can, and I'm going to have to work a lot faster and crazier because it's only going to get a lot worse. And this is serious stuff. We have had no deaths, thank God, from COVID-19 among homeless people, as far as I know, except there was a case in Santa Clara I heard about someone who was in the encampment. But in San Francisco, that hasn't happened. It's going to happen, guys. But we're going to start seeing people getting hospitalized from this illness over the next few weeks. It's going to be really a scary, scary time. So get ready, get strong, get compassionate, demand the resources. Do not sit idly by and let the voices of homeless people not be heard. This is our time to be our greatest advocates. We cannot be passive in this time. It is the next 3 weeks that will be critical to being able to diminish the amplitude of this exponential growth. And if we don't do our job well in the next week, we're going to be seeing the suffering at a much greater rate than we should. So this is the time.
I did want to add that I know violence isn't always at the top of people's minds, but I unfortunately think that the deaths as well as the injuries from violence are going to rival the number of COVID deaths, unfortunately. So I do think that we do have to keep in mind all of the other types of, social injustice epidemics that we have concurrently happening with the injustice of people being unhoused, as well as how this spreads in communities experiencing all of these inequities. So just to keep in mind that this is intertwined with multiple other pandemics in our society.
Absolutely. So I think we have, oops, sorry. Time for one more.
Great. I think Paula might be working out some technical stuff. I do think that's a great note to end on. I do want to say there are a lot of questions that we weren't able to make it to today. And we'll be doing our best to answer those questions and get back to people as soon as we can. And some of these are questions that will be good to get back to people individually, and some of them will be great questions to answer for the group at large. So I'm really excited for that. And we'll be working on getting that to you as soon as possible. Paula?
I just wanted to add that to just remember, since Josh just told us how this is going to be peaking over quite a number of weeks, is to really please do take care of yourself, because it's quite a marathon, and we're going to continue to need to take care of one another and ourselves.
Oh, hi, everybody. So Paula's audio, there's something funny going on. So I do really want to thank everybody for being here today. And please let us know if you have any additional questions. Let us know if there's any other bodies of knowledge that you want addressed beyond what we talked about today, like what's going on the streets, what's going on with food security, what's going on with violence, because we're still gathering information, still learning things, and still planning on making these webinars happening to let everyone in the community know what's going on. So great. Really like to thank our panelists once again for coming and talking. Y'all were fantastic, and I learned a lot today as well. So thank you so much.
Thank you for all the work you're doing.
Thank you.
All right, everybody. Have a wonderful day. Thank you.